And today we are going to show you a video in which you're going to see patient with anterior uveitis, which is a complicated case. And we initially go to run through the video in which you can see that there is a very shallow anterior chamber. As you sweep the light from one side to the other side, the anterior chamber is very shallow, and the reason for that is iris bombae due to the presence of Secluso Pupillae, which is causing this iris bombae in this patient. And let's stop the video and draw over here for you. And if you see, this is the tool which you're using. So if I draw over here, this is the area where we've got the posterior synecdoche present 360 degree, and if they are present 360 degree and they divide the two cavities of the anterior and posterior chamber, they are called a secluso pupillae, right? And if the similar thing was happening, that there was a dense pupillary membrane covering this area and occluding the pupil, that would be called occluso pupillae. So this patient has got a secluso pupillae compared to an occluso pupillae, which we can see in patients. And next thing which you see over here is, I'll just move this forward the video slightly or backward, and you can have a better view of this area. So what do you think this area is? This area is the area of the iris which is stuck to the endothelium. This is called a PAS, or posterior anterior synecdoche formation. So this is an area which is important. We've got this area which has got the posterior synecdoche producing secluso pupillae. And then you've got ciliary congestion. So whatever is happening, this is an active disease, and the cornea is giving you a hazy appearance all the way in this patient. And if we go forward, then we want to check what is the thick or the depth of the anterior chamber all around. If you see, this is the corneal layer which is present on the slit lamp, and this is this reflection from the surface of the iris. You can see it's a very slit-like. I've just exaggerated this, probably the better line. If I draw the lines again, it is better to show it over here. And is actually, this is the thickness. It's a very slit thickness over here, and this is the thing over the lens. And this is all over because the iris bows forward. So if you have it like this, iris bombae is something, iris is bowing forward like this, and that is actually producing. So if this is the cornea, the iris is bowing forward all the way around, and this is producing shallow anterior chamber all the way, as you can see in this video. If I take this video around, you can see this is shallow anterior chamber. So you've got a patient who has got chronic uveitis, which is produced posterior synecdoche all around, and it's produced iris and bombae and secondary angle closure glaucoma. What would you do with this patient? The next thing is you will go in. If you look at this patient again, and if you look at the area which you have, you would do a YAG iridotomy over here, and you could do a supranasal and a supratemporal, and that would immediately open the two chambers and reduce the pressure. The other thing, next thing you do is to start off with topical steroids to reduce the inflammation, then use topical and systemic pressure reducing medication, anti-glaucoma medication to reduce the pressure. And your long-term aim would be, if it's a severe uveitis, you would like to go ahead and do a B scan to check if a vitritis is present. And if it's too much of inflammation, you would consider either a posterior subtenon Canacort injection or oral systemic steroids or immunosuppressive treatment to control this uveitis. And once it's controlled and the patient has got good vision, your aim would be to plan for surgery, and that wouldn't happen until 3 months when the inflammation is controlled in the eye. And once that is achieved, then your aim is to go and do surgery and release the posterior synecdoche, and then use vision blue to stain the capsule, and then do either a phacoemulsification, or you would try to remove that capsule as well and leave the patient aphakic, so there's no posterior synecdoche formation. And if you choose to put an intraocular lens, then heparin coated lens would be the treatment of choice. Well, the long-term complications would remain glaucoma, endothelial decompensation, and there's also a chance that while you're doing surgery, you can try to open some of the peripheral anterior synechial formation. So this is a case which is very important and that could come in an examination for assessment, and it's very important that you have your mind clear about how you're going to answer this and what are the correct answers to this. Thank you very much for watching, and we look forward to seeing you again.